well, we will go ahead and get started. Good afternoon, everyone, and welcome to today's webinar, Nurses' Role and Assessment in Domestic and Intimate Partner Violence, Identification and Care of Victims. I'm Dr. Monica Briggs, the Project Director for the Tennessee Center for Nursing Advancement and the sponsor for today's webinar. The Tennessee Center for Nursing Advancement is dedicated to supporting and empowering the nursing workforce across our great state and in the Appalachian Highlands. Our mission is rooted in advocacy, education, and collaboration as we work to strengthen the nursing profession, address workforce challenges, and ensure that the delivery of high-quality care in every community in Tennessee and the Appalachian Highlands. We serve as a resource hub for nurses, healthcare organizations, policymakers, and educators, providing critical insights, tools, and initiatives to tackle current issues and prepare the future of healthcare, whether it's through workforce research, leadership development programs, or partnerships that bring meaningful change. We are committed to advancing the role and impact of nursing in every corner of our state and in the Appalachian Highlands. Today's webinar is a chance for us to connect, learn, and explore how we can continue to make a difference together. Before we dive in and introduce our speaker, let me take a moment to cover a few housekeeping items for today's webinar. All participants, please remain muted during the presentation to minimize distractions. If you experience any technical difficulties, please use the chat box and our team will assist you. We encourage you to ask questions. Feel free to type your questions into the chat box at any time during the presentation. We'll address them during the designated Q&A session at the end of the webinar. This webinar is being recorded, and a copy of the recording and any shared materials will be sent to you to all registered participants afterwards, so you can revisit the information and share it with your colleagues. It'll also be posted on the center's website at tcfna.org. All participants will receive a participation certificate via email after the webinar, and at the end of the webinar, you'll receive a brief survey. Your feedback is incredibly valuable to us as we continue to improve and deliver meaningful sessions like this one. With that out of the way, it is now my pleasure to introduce today's speaker, Carla Kirkland. Carla Kirkland is a retired emergency department nurse practitioner and holds certifications in acute, primary, and emergency care. She is the past president of Tennessee Nurses Association and was the Tennessee State Liaison for American Association of Nurse Practitioners from 2023 to 2025. She now resides in Jackson, Tennessee. So please join me in welcoming Carla.
Good morning. Let me get this pulled up. All right, good morning. I am Carla Kirkland, as mentioned, and I appreciate this opportunity to share information with you on this very important topic. This presentation was originally created in conjunction with Memphis Area Women's Council, of which I'm a former board member. Some of the goals of the Women's Council include to advocate for women and girls in our community and to increase services, shelter, and victim advocates for victims of domestic crime. Deborah Clubb is the executive director for the Women's Council, and you will hear me refer to her a couple of other times during this presentation. And I do have a lot to get to today, so I may talk fast. I have no conflict of interest to disclose. I do need to give a trigger warning before we get started. This presentation contains content which could trigger sensitive memories for some people. If you're having difficulty with the discussion, please feel free to step away. This presentation does contain a lot of heavy material. It's intended to give background on domestic abuse and how nurses can help patients. But many of us have friends or family members who may have also been in abusive relationships, or some of you may have been. There will be information on how to help all of these people during this presentation. Objectives today define which areas of the population are most vulnerable to domestic and intimate partner violence, recognize at least 5 behaviors of abusers in domestic and intimate partner relationships, list at least 5 tips for navigating patient care when working with domestic and intimate partner violence victims. Throughout this presentation, I'll also bring in some concepts of nurse leadership and using your nursing voice and experience, as well as the importance of community awareness and involvement. So just a little bit about my background. I received my BSN at Harding University in Searcy, Arkansas. Went to UT Health Science Center in Memphis for my MSN and acute care nurse practitioner, and then went back to UTHSC for a postmaster's FNP when I went to the ER. I've been an ICU nurse. I worked for an internal medicine group first as their RN and then their nurse practitioner. And then my last 18 years, I was in an emergency department in Memphis at a hospital, and I retired July 1st, and I'm loving it. So why should I care about all this? Well, I want to give you a little background on how this presentation came about. First, my role as a nurse practitioner in the emergency department. I would see and treat domestic violence victims in the ER, but I didn't always know what to do to help them beyond treating their injuries. And then I became acquainted with Deborah Clubb with the Memphis Area Women's Council, and I began attending some women's council meetings and events. Then one day in 2021, I received, those random emails that we all get, an invitation to attend a forum at University of Memphis on domestic violence. So I went to learn more about the subject and to hopefully be better able to help my patients. Afterward, forum attendees received an email asking for participants who might be willing to serve on a task force to work toward goals of streamlining care to DV victims in Shelby County, and I accepted that invitation. So we learned at the forum that this was an initiative through a grant from the Tennessee Office of Criminal Justice Programs. Prior to the forum, evaluations had been completed, which determined there actually were a lot of community services and education in Shelby County, but no coordination of efforts between the stakeholders or streamlining of services, leading to many frustrations regarding the level of DV services in Shelby County. For instance, I might be seeing a patient in the emergency room at 3 in the morning, and it would be difficult to refer to a safe shelter at that time. By being a part of this task force, I was able to meet people involved with various community agencies and bring my nurse's perspective to the conversation. So I was able to meet and work with Memphis Police Department officers, Shelby County Sheriff's Office, Bartlett Police Department, University of Memphis, Shelby County District Attorney's Office, Domestic Violence Court Judge Craig Gilbert, the Family Safety Center, Hope House, Agape Child and Family Services, YWCA, Heal 901, Rape Crisis Center, Community Alliance for the Homeless, Love Doesn't Hurt, and Memphis Area Women's Council. So I do encourage you to network with community agencies and get to know what they do and provide your nursing perspective. When I attended the initial forum, I really had no idea I would get so involved in all of this. When we were broken down into task force subgroups, I was initially assigned to a service provider group, which was made up of me, a nurse, and law enforcement. Memphis Police Department, Shelby County Sheriff's Office, the District Attorney's Office. I wasn't really sure how a nurse related to those groups, but I learned a lot about their roles and perspective. I was later changed to an educational focus group, and I was the only nurse on the task force in the beginning as far as I knew, but I was able to pull in other nursing groups like Merge Memphis. It was started by nurses Keith and Sherry McClure, and Merge Memphis provides shelter for homeless women. UT Health Science Center College of Nursing has a grant to fund expansion of sexual assault nurse examiner or SANE training and certification in West Tennessee. And then by me being a nurse practitioner at St. Francis ER, I was able to bring in that perspective. By being past president of TCNA, I brought in the perspective of nurses around our state. And being a past state liaison for AAMP, I was able to bring in perspective of nurse practitioners around our country. At one of our task force meetings, one of the facilitators asked about education for nurses or nursing students. In my past leadership roles, I was familiar with many School of Nursing leaders, so I did accept the challenge of putting together a nurse-specific presentation regarding nursing care of our patients who may be abuse victims. I've given this presentation at several schools of nursing and at nursing conferences so far. This was just a slide from a forum update held at University of Memphis, summer of 2023. to create more advanced goals and efforts among stakeholders involved. So before we define the nurse's role, let's get some background on domestic and intimate partner violence and see how all this fits together. A succinct definition of domestic violence is a pattern of coercive control that one individual intermittently exerts over another. And a definition of coercive is using force to persuade people to do things that they don't want to do or are unwilling to do. United Nations definition, domestic abuse, domestic violence, and intimate partner violence are sometimes kind of used interchangeably. And actually today I may collectively use the term abuse to talk about all of them. It's a pattern of behavior in any relationship that's used to gain or maintain power and control over another person. Abuse can be physical, sexual, emotional, economic, or psychological actions or threats of actions that influence another person. So throughout this presentation, keep in mind that domestic and intimate partner violence is all about power and control. Remember, power and control. Also today, keep in mind that abuse is not just physical violence. Still with the UN definition, it includes any behaviors that frighten, intimidate, terrorize, manipulate, hurt, humiliate, blame, injure, or wound someone. Abuse can happen to anyone of any race, age, sexual orientation, religion, or gender. Domestic and intimate partner violence victims are most often women, so that will be the default of this presentation, but know that it can also happen to men and children, but this presentation will not get into child abuse today. DV can occur within a range of relationships, including couples who are married, living together, or dating, and it affects people of all socioeconomic backgrounds and education levels. Under Tennessee state law, domestic violence covers family members and household members, including roommates. So it could just be roommates living together, could be violence between a mother and a son, or a grandson and a grandmother, or an uncle and niece. Intimate partner violence is violence between couples who are married or living together, or people who were dating or previously in an intimate relationship. Unfortunately, Tennessee law only addresses physical abuse. We learned from the UN definition that in an abusive relationship, there's a pattern of behavior which is used to gain or maintain power and control over another person. So let's look at some examples of what controlling partner behavior can look like. The abuser may create feelings of guilt for normal things like needing alone time or not having dinner ready. There may be negative put-downs and sarcastic comments disguised as jokes or teasing. They may move too fast in the relationship, may strongly suggest how their partner dresses, who they can see, and where they can go, may blame others for their mistakes and problems, check their partner's phone, email, and/or internet search history. I had a friend whose husband did that. Keep their partner from seeing friends and family and sabotaging their relationships. Make statements like, if you loved me, you would, whatever. They may criticize their partner often, take no responsibility for their actions, be hypersensitive and easily insulted. They may deny that this is abusive behavior, may threaten to harm themselves. There may be a lack of trust, extreme jealousy, cruelty to animals or children, think the whole world is against them, may buy extravagant gifts or outings to create feelings of indebtedness. There may be threats of leaving or cutting off privileges like access to your children or bank accounts. Need to always know where their partner is or constantly checking in. There may be gaslighting, lying and manipulating to make their partner doubt reality. They may indicate their love or attraction is conditional, like, you'd be hot if you spent more time on your hair. I had a good friend who was in a marriage to a man that I later found out was very controlling and jealous. He was very overbearing, and she did end up divorcing him. She and I were talking a little while back about my daughter's wedding, and I was thinking she had been there, but she said she wasn't, and she always regretted not going. But her husband, which I didn't know at the time, was very possessive and controlling and always tried to prevent her from seeing family and friends, sabotaging her relationships. Some myths about domestic violence. It's a myth that it's unusual, a myth that it's impossible to love someone who abuses you. A myth that it only happens when someone flies out of control. A myth that it only happens to those who are poor, dependent, or uneducated. A myth that there's no good reason not to call the police. A myth that if someone abuses you, it's an obvious decision to leave the relationship. A myth that it's always physical. A myth that women abuse men as often as men abuse women. A myth that men are never victims and women are never abusers. And it's a myth that both parties usually hold some responsibility. In the next few slides, we'll see some statistics on abuse in our communities. And as we're looking at these, y'all remember, these are our patients. These are who we treat every day. In the US, 1 in 4 women and 1 in 9 men experience physical violence from an intimate partner. Domestic violence is the leading cause of injury to women, more than car accidents, muggings, and rapes combined. Men who are victimized are substantially less likely than women to report their situation to police. Only 13% of intimate partner assaults are reported to law enforcement. Women with disabilities have a 40% greater risk of violence than women without disabilities. 1 in 4 adults have some sort of disability. 3 in 4 people with disabilities experience some form of abuse. And when I saw that, I thought 3 in 4 people experience some form of abuse sounded like a lot to me. But when you consider that what domestic violence could look like for a victim with a disability, it could be verbal and psychological abuse, neglect, physical violence, threats and intimidation, unwanted sexual contact, isolation, withholding medications, physically harming service animals, depriving victims of necessary physical accommodations, withholding or destroying assistive devices such as wheelchairs, and there's financial exploitation or misusing the victim's money. Black women are 35% more likely to experience domestic violence than white women. Native Americans experience a significantly higher risk for domestic violence than the general population. 30 to 50% of refugee and immigrant women experience domestic violence. And it's, of course, in the LGBTQ community. There's physical violence, threats and intimidation, verbal harassment, sexual violence, and in 10% of cases, a weapon may be involved. 1/3 of students who've ever dated reported they had experienced physical violence in the dating relationship. Controlling behavior in dating relationships can start as early as middle school, which I had really never thought about. Some of the stakeholders on this Shelby County DV task force are working to get into middle and high schools or after-school programs to teach healthy dating relationships and behaviors. 1 in 5 teenage girls said they've been in a relationship where the boyfriend threatened violence or self-harm if a breakup was to occur. Among college students that experienced an abusive relationship, 70% did not realize at the time they were in an abusive relationship at first. 60% said no one stepped in to try to help them, and 42% kept the abuse private and didn't tell others about it. I gave this presentation at a nurses conference a couple of years ago. One of my good friends came up to me afterwards and shared that she had been in an abusive dating relationship when she was in nursing school. She did break off the relationship, but she still had difficulties because the former boyfriend was also in her nursing school class. Many young victims feel pregnancy will help them get out of a bad situation, but a large number of pregnant and parenting teens are beaten by their partners. The U.S. Preventive Services Task Force reports that evidence suggests that pregnancy is associated with an increased risk of the initiation of physical violence among women whose partners did not want the pregnancy. It's also associated with an increased risk of continued physical violence during pregnancy in women with an unintended pregnancy who was already experiencing physical violence prior to conception. In 2003, there was a revision to the U.S. Standard Certificate of Death that has enabled more comprehensive analysis of violent deaths occurring during pregnancy and the postpartum period. Data is confirming that homicide is a leading cause of death during pregnancy and the postpartum period in the United States. Pregnancy and the postpartum period are times of elevated risk for homicide among all females of reproductive age. A recent study found that 7 out of 10 pregnancy-associated homicides involved a firearm, likely a reflection of the broader national increase in gun-related homicide occurring over the past decade. How many of you would have thought of stalking as a form of abuse? I had really never thought about that. But 1 in 6 women and 1 in 17 men experience stalking in their lifetime. Common stalking behavior may include unwanted contact, leaving gifts, following or spying, spreading rumors, showing up places unannounced, waiting for victims. I was talking to a patient, a young lady in the ER one night at the triage window before she was about to leave, and a man came up beside her and stood beside her. And when she saw him, she looked very uncomfortable and scared and asked him why he was there. I asked her if she needed to be brought back to where I was, and she said yes. So I brought her back through a locked door, and she said he was an ex-boyfriend who was apparently stalking her. So we waited a few minutes, and then security escorted her out. Stalking victims suffer much higher rates of depression, anxiety, insomnia, social dysfunction, and 1 in 4 stalking victims contemplate suicide. Once again, y'all remember, these are patients we see every day. 7 out of 10 emotionally or psychologically abused women display symptoms of PTSD and or depression. 1 in 5 homicide victims are killed by an intimate partner. Some of you may have heard about the death of a first-year medical student attending UT Health Science Center in October of 2024. She was participating in a breast cancer awareness walk at Shelby Farms Park in Memphis. She was shot and killed at the park by her ex-boyfriend. More than 75% of women aged 18 to 49 who were abused were previously abused by the same perpetrator. Domestic violence incidents involving firearms are 12 times more likely to result in death than incidents involving other weapons or bodily force. Disputes in domestic and intimate partner relationships have become more deadly because guns are being brought into arguments more frequently. Guns are now being brandished in every kind of dispute, even minor ones. All disputes with people making gun threats must be strictly avoided. The CDC reports that firearm violence and injuries are a serious public health problem that impact the health and safety of Americans. This cycle of abuse diagram is frequently discussed during the study of domestic and intimate partner abuse, so I did want to review that with you today. Early in a relationship, a lot of times there's a honeymoon or calm phase. It may begin with a period of non-abuse. It's typified by peaceful and loving behavior from the abuser. There may be flowers and romance and good times. Then tension develops. The victim may feel like they're walking on eggshells. Usual life stressors become excuses for the abuser to justify their controlling and abusive behavior. The abuser may anger quickly, set rules or expectations and change them without warning. The victim feels pressure to calm the abuser and not do anything that could irritate them. They feel they can't do anything right or good enough and feel powerless. Then there can be an explosion phase, which is characterized by a significant incident or intense period of abuse, which may lead to actual acute physical harm. The abuser seeks to prove their power over the victim. This can be very terrifying for the victim, and they may feel hurt, shocked, ashamed, degraded, and feel as though the abuse is their fault. This can last anywhere from a few minutes to several days and often becomes more intense as the cycle repeats, with less and less time between explosions and incidents. Then there can be a period of denial. The abuser may minimize the explosion or incident and blame it on the victim or others, or on drugs or alcohol or stressful circumstances. They may completely deny the explosion occurred at all, so the victim may fear nobody will believe them. Or the abuser may apologize and express shame or guilt, promising it will never happen again. And the abuser may really believe this. And victims want to believe the abuser and hope the loving behavior marks a decisive change that the abuse will not recur. But then the cycle continues and we return to the honeymoon phase with flowers and better times and hope for change. However, this phase often shortens and disappears over time. Y'all, I know that was a lot, but once again, this is happening in our communities and to our patients and families and friends, and we need to be educated about these issues. So where does the nurse fit into all this? Y'all, we are everywhere in healthcare, right? Nurses work in and assess our communities in many various roles. We are there for hospital admissions and annual exams and prenatal visits and sports physicals and pre-employment exams, trauma-related visits, and follow-up for chronic problems. The most important thing nurses can do to address domestic violence is to ask all women about violence during every patient encounter. Focus on behaviors. Avoid the terms violence or abuse. Women may not have the same interpretation. When a woman does disclose abuse, the nurse should validate her experiences and fears. The U.S. Preventive Services Task Force has recommended that clinicians screen for intimate partner violence in postpartum or pregnant people and women of reproductive age. So women of reproductive age is just about everybody, right? 13 to 50. Assessing at every patient encounter may be easier in some patient care situations than others. For instance, in the emergency room, my job is to try to get patients in and out as quickly as possible. Screenings may be more feasible in a primary care setting or women's health setting. Victims of domestic violence will often discuss their experiences related to violence if inquired about in a non-judgmental, empathetic, and direct way. Some key screening questions to ask. Do you feel safe or comfortable in your current relationship? Has anyone ever forced you to have sex when you didn't want to? If yes, who? Do you currently have any contact with him or her? Have you ever been slapped, hit, or kicked by someone? If yes, who? Do you currently have any contact with him or her? Notice that the words violence and abuse are not used in these questions. Screening tools and forms are available that can be utilized during routine visits, intake forms, or patient histories. As I said earlier, screening questions may be easier to ask at each primary care visit or women's health visit. I've been told that some computer charting systems, such as Epic, have screening questions built in. I have a friend who had an outpatient women's health procedure done, and she said she was asked these questions. Keep in mind some obvious signs of abuse when you're evaluating your patients. Unexplained contusions, lacerations, bite marks, or burns. If the patient presents with questionable explanations for injuries, such as falling or slipping. More subtle complaints may be delays in seeking care and repeat visits for chronic or seemingly minor medical issues. Sometimes when seeing a patient in the emergency room, I'll look back at their previous history. Occasionally, I'll notice patients who are maybe otherwise young and healthy, but seem to come in for frequent falls or accidents, or have had more x-rays than usual for injuries. Seen a lot of people with complaints of falling off the porch and sliding down the stairs. Notice repeat visits for emotional issues, chronic GI problems, chest pain, or headaches. These can be physical reactions to trauma. Be on the alert for potential red flags. A dominating partner who attempts to control the clinic visit or consistently speaks for the patient. A patient's silence when the abuser is present may indicate controlling or manipulative behavior by their abuser. It's crucial to find an opportunity to talk with the patient privately. Maybe take the patient to the restroom and say you need a urine specimen and speak to them there. Often in the ER, I would evaluate patients in the triage area because we had so many admission holds that we didn't have rooms to take patients straight back to. So when I would call a patient back, I would try to bring just the patient back to speak with. If other people got up to come back with them, I would ask them to just have a seat and the patient would be right back out with them in just a minute. So why don't nurses evaluate for abuse? What are some primary assessment barriers identified by nurses? Could be language barriers, cultural differences, fear of repercussions of mandatory reporting laws, frustration associated with the futility of responses of healthcare systems. Maybe the nurse has a personal history of exposure to abuse and just doesn't feel comfortable. They may fear offending victims. There may be a lack of privacy, like when I'm talking to people up in triage, a lack of knowledge of resources available for victims, time constraints, or lack of training. What are barriers that patients face? Why don't they report abuse? They may fear police involvement, maybe socioeconomic factors, shame and fear of retaliation. And we're going to talk a lot more about this in later slides. Be on the lookout for risk factors for homicide. Does the abuser have access to guns or other weapons? Have there been threats of homicide or suicide? A history of substance abuse, forced sex, extreme jealousy, dominance, or obsessiveness? Has there been a history of extensive property destruction, weapon use in prior violent incidents, increasing violence over time, or violence toward pets or children? One way the nurse can help is to educate victims on creating a safety plan and some components of a safety plan. Advise the patient or victim to secure and make copies of the following in a readily accessible, safe place: important papers, house and car keys, community resource phone numbers. Instruct the victim to identify safe or safer areas in the house, areas with more than one exit, and areas that don't contain items that could be used as weapons. If possible, always have an easily accessible phone. The victim should talk to their children about safety, tell them not to get involved in the violence between the victim and the abuser, teach them how to get help, and practice the safety plan with them. Establish a code with family, friends, and neighbors. Hide extra clothing and money. Identify behaviors of the partner that may indicate increased danger. Change the locks. Consider a security system and motion sensor outside lights. This Shelby County Domestic Violence Task Force involved a group that would give out free Ring doorbell cameras and assist with setup. Tell child care providers the names of people who are allowed to pick up your children. Give teachers and babysitters a copy of an order of protection if you have one. Open a bank account or get a credit card in your name. You may need to get a P.O. box in your name. This slide has a lot of information and it isn't always feasible. We've talked about some of these, but these items are good to have if the victim can get them. Unfortunately, the abuser may control access to many of these items. It can be difficult for those who haven't experienced abuse to understand why victims decline help or stay with their abuser, but it's crucial to avoid blaming the victim. In the ER, I would frequently wonder, and I would be very confused as to why victims wouldn't file a police report or just try to leave an abusive situation. Don't be this person. Don't blame the victim and judge them. Don't say or think things like, "Isn't he your boyfriend? That's crazy. She'd never do that. You shouldn't have had so much to drink. What were you wearing? Why didn't you fight back? Are you sure you said no? Boys will be boys." I met with a representative from the Safe Hope Center in Jackson, Tennessee a couple of years ago who had accompanied a victim to the local ER for a forensic exam. She said the sexual assault nurse examiner was very professional and caring, but the ER nurse was not. We may need to model compassionate, professional behaviors for our colleagues. Recognize that DV victims may feel stuck in their situation due to economic or emotional dependency. Children, belief that they have no place to go. They may have no place to go. Low self-esteem, fear of the unknown, disbelief that this is abuse. There may be religious or cultural beliefs keeping them in the situation. There are many reasons why people remain with abusers. There may be justifiable fear. If the abuser says to the victim, "If you leave me, I will hunt you down and kill you or harm the children," they probably believe that. There may be practical concerns about food and housing, worries about the well-being of children or pets. Here's some more reasons why abuse victims stay with controlling partners. Leaving can be dangerous, like we just talked about. Hope for change, as we saw in the cycle of abuse. Isolation, societal denial, barricades to leaving, economics, could be immigration issues. And leaving is a process, like we saw in the slide about preparing an emergency kit. A survey of survivors found that 65% of respondents reported that concerns about their pet's safety impacted their decision to enter a shelter, with 85% reporting they delayed seeking a shelter as a result. I have been told that some communities have pet shelters for temporary housing for pets of women and children seeking safe shelter. More than 50% of requests for services made by survivors in the U.S. that cannot be met are for housing and shelter. One of our primary goals as nurses is to work with our patients to develop a safety plan regardless of whether the steps include leaving the abuser. In the ER, I may just be able to give the patient some follow-up resource information. Approach your patient with empathy. Understand that the victim's attempts to leave or pull away from the abuser can often lead to an escalation in violence. Efforts to persuade the victim to just leave the relationship are unwise unless a strong safety plan is in place. On average, it takes 7 attempts to leave an abuser. After giving this presentation at one school of nursing, the instructor came up after the presentation and shared that her sister had been in an abusive relationship, and it took her 10 years to leave. She wanted to wait until all of her children graduated from high school. This is another example of leaving being a process. So some tips for navigating patient care for DV survivors. Survivors have had their choice taken away time and time again, so it's vital to understand and let them choose whether to disclose abuse or violence and understand the possible consequences of disclosure and reporting. If there's a language barrier, always use a professional interpreter instead of staff or a family member. This reduces the potential risk that the patient may misunderstand the conversation or the conversation may be reported to the abuser. In the ER, we had the iPads with video interpretation on it. That was just a life changer. That was so helpful. Tips for navigating patient care. Nursing staff should develop strong relationships with community stakeholders and keep printed resources or share with survivors. Of course, this task force I was on helped me develop those important relationships with community stakeholders and know what resources were available in the area. Ensure that printed materials can't be accessed by the abuser. It places the survivor in significant physical danger. Don't talk down or belittle a victim based on your judgments of their situation. Remember that the patient may need help with insurance estimates or costs, since the abuser may control the money or insurance. Follow through and be reliable. You may be the only trusted person in the victim's life. Don't assume that the patient isn't a survivor. Don't assume what they're feeling or what's best for them. Don't assume that it's easy for them to leave an abusive relationship. Do, however, be patient and even-toned. Give your patient information and options for medical treatment. Ask permission before touching the patient. Remember, abuse victims and survivors can be of any gender. They aren't just women. Ask about their children's health and offer referrals or exams if possible. Don't assume your patient isn't worried about his or her children's health. They often stay in abusive situations because leaving can be more dangerous. One thing that Deborah Clubb with the Women's Council shared with me is that often victims just want the abuse to stop. They would prefer not to leave the relationship, leave where they're living, take their children out of school. They just want the abuse to stop. Nurses should stay focused on patient care, safety, and trust. In Tennessee, we do have mandatory reporting. Emergency departments are required to report all assaults or violence-inflicted injury to the police. All healthcare providers also are required under Tennessee law to report to DHS or DCS any suspected child abuse or abuse of a person who may be in need of protective services, such as the elderly. If in the process of a non-traumatic visit, your patient discloses a history of abuse but doesn't want to report it to authorities at that time, there's no obligation for the nurse to report. Giving them resources and documenting the same is appropriate. So, for example, if your patient comes into the clinic for the flu, or they're at a women's health visit for an annual exam and during the screening questions, they reveal a history of abuse. If they're there for a non-traumatic visit, it's not required that it be the authorities be notified. But always ask, are you in danger and do you need assistance? If your patient applies that they are in danger and need assistance but decline a police report, offer social services involvement and document your actions. Assess your patient's immediate safety needs. Directly ask if she feels safe going home. If it's determined your patient is in danger, assist in accessing community resources or shelters. The likelihood of abuse occurring again, escalating, and increasing in severity is great. A young lady I know who had worked as a hospital unit secretary, was shot 20 times as she sat in a car in April of 2025. She had left her abusive husband and he tracked her down and shot her. She's the mother of 4 children. Miraculously, she survived and spent several months in the hospital. She has permanent disabilities, but I understand she's been discharged from the hospital and is now home. So I don't know how many of you are familiar with Tennessee Justice Center, but it's a nonprofit public policy advocacy organization and law firm based in Nashville. Their mission is to use the law to advance economic, racial, and social justice by working for and with Tennesseans seeking better lives for themselves and their neighbors. And y'all, they have really great webinars. I attended one of their webinars on domestic violence in November 2024, which was a panel discussion with experts from around Tennessee, with panelists from YWCA Nashville Domestic Violence Shelters, Hamilton County and Chattanooga Family Justice Center, Branch House Tri-Cities, and RAP of Decatur and Benton counties. I wanted to share some key takeaways the panelists have observed in their work with victims. They have observed that DV survivors have increased incidence of health problems, heart disease, stress factors, diabetes, increased risk of breast and cervical cancer since many are unable to get screening exams. The abuser may control the money and bring the victim to appointments. Nurses need to provide health care, resources, and support for when the victims are ready to leave. They describe some barriers to health care for victims of DV. One of the biggest barriers, of course, is the abuser. They may lack financial resources and insurance, may lack transportation, childcare. If they are insured, the abuser may have access to the patient records if they provide the insurance. The victim may fear for privacy in small communities, whether rural or urban. Everybody knows everybody. Education is mental health. Education and job training are a ticket out of a domestic violence situation. The panel also mentioned the importance of screening for traumatic brain injuries, or TBI, which is a significant problem for victims and their advocates. Misdiagnosed TBI is sometimes waved away as addiction, mental health issues, or other health problems. Victims may be screened out of shelters because they're thought to be an active addiction. TBI may adversely affect victims' short-term memory, making the care more complicated and making it necessary for victims to rely even more on caseworkers who make sure they're connected to the care and resources they need to restart their lives. So some screening questions for TBI. Have you been hit in the head? Were you in the hospital for it? Probably need to ask also how many times they've been hit in the head for repetitive brain injuries. Have you been pushed against a wall or other surface? Have you been pushed down a flight of stairs? Have you experienced violent physical shaking or strangulation? And some strategies for working with victims after TBI. During meetings, you may need to reduce unnecessary distractions such as bright lights and noise, develop safety planning in smaller and more frequent steps, aid in the development of checklists, goal creation, and time management, allow extra time for your patient to complete tasks such as forms, phone calls, and decision-making. Be factual, realistic, and concrete in your statements. Break information down into small pieces. If safety allows, write important information down in a journal or calendar, like court dates, contact numbers, directions, order protection, and so on. Help the victim or survivor optimize management of their lives in terms of accessing benefits, rehab and support services, assistive devices, service animals, and independent living. Provide respectful feedback on problem areas that affect the safety and possible consequences of long and short-term decisions. And some of these strategies may apply more to social workers or case managers, but they're still important for us as nurses to consider in caring for victims. So I know this has been a lot of information, and we are getting closer to the end, but I want to review just a few points that are very important that I want you to take with you. I want you to remember that domestic and intimate partner violence occurs at all socioeconomic levels and in all types of communities. Given the statistics we reviewed earlier, it is practically impossible that you will never meet anybody who has experienced some form of abuse. You probably know more victims or survivors than you realize. Domestic abuse is not only physical abuse. Verbal, emotional, psychological, financial, spiritual, sexual, and technological are all forms of domestic violence. There are many factors and extreme safety concerns that can make leaving an abusive relation difficult. It is the most dangerous time for a victim. Abusers may, in fact, have an anger problem, but they choose who they can victimize and who they can't. For example, they won't lash out at their boss, but they won't hesitate to use violent force on others. Alcohol and drugs may aggravate a DV situation, but they're not a cause or excuse. Impaired abusers have carefully chosen their victims and will control and harm their victims whether they are under the influence or sober. They're separate issues that may or may not overlap. The Memphis Area Women's Council, I don't know if you can see this, developed little pocket cards that can be given out to abuse victims. They're small, they can be tucked away in a pocket or purse or behind the cell phone in a cell phone case, much better than the 30-page ER discharge instructions I would give out. I found them very helpful to give out in the emergency room. There is actually a National No More website, which is listed on the slide. So this is the front of the card. This is the back of the card. It says, no one deserves to be battered or abused, terrorized, or threatened. All sexual contact without consent is against the law, even by a spouse. Get help for yourself and your children or for friends, relatives, or coworkers. Be smart. If you're being abused, make the call away when you're away from the abuser and plan carefully. Keep this card for your future use or share it with someone who needs these numbers. You can save a life. And then on the inside of the card, it had resource phone numbers. Remember the slide from earlier. Victims of domestic violence will often discuss their experiences related to violence if inquired about in a non-judgmental, empathetic, and direct way. Y'all, people love us. Nurses are voted yearly as the most trusted profession. As nurses, we have the ability to make a huge impact on the lives of our patients and their families and our communities. Be alert for opportunities to learn more about healthcare-related matters in your community. Attend conferences and seminars. Watch for opportunities to learn, grow, and network with other nurses. Check out those random emails that you get every day with educational offerings. Be involved in local, state, and national nursing associations. Attend political town hall meetings, picnics, or forums to meet candidates running for election and learn their views on healthcare. They are the ones who pass laws that help or hinder issues affecting the nursing profession and the healthcare of our patients, including laws affecting domestic abuse. Use your nursing voice and experience. Be a registered voter and vote in every election. I do have some breaking news. As of January 1st of this year, Savannah's law went into effect. Tennessee is the first state in the nation to launch a public domestic violence offender registry. It applies to people convicted of domestic violence offenses at least twice. The registry will be managed by the Tennessee Bureau of Investigation and will include the offender's name, photograph, date of birth, date and county of conviction, and it's available for public inquiry on the internet. Lawmakers say the goal of the law is to give people access to information that previously required digging through court records across multiple jurisdictions. The bill is named after Savannah Puckett, a Robertson County Sheriff deputy who was killed in 2022 by her ex-boyfriend, who later pleaded guilty to first-degree premeditated murder and is now serving a life sentence. It was only after her death that investigators uncovered his history of domestic violence and stalking, information that was not easily accessible at the time. So we've covered a lot of heavy information, and I wanted to close on a more upbeat note. I want to remind you that community education can be fun. Memphis Area Women's Council sponsors Walk a Mile in Her Shoes every year. It's a rally and 1 mile walk to raise awareness about domestic and intimate partner violence, and more especially to educate men on what abused women go through. Men are invited to wear women's shoes while they walk, which are provided by the Women's Council, or they can bring their own. This is a picture of the September 17th, 2024 Walk a Mile event, which started at University of Memphis, and with a police escort, participants walked with signs on busy area streets to increase community awareness. Here's a picture of domestic violence Judge Greg Gilbert and Memphis Police Department Assistant Chief of Police Services Don Crow wearing their heels and carrying their signs just before the walk. Around this time also, we learned that Judge Gilbert grew up in an abusive home. Here's a picture of some of the guys in their heels and a picture of Women's Council board members and volunteers from that day. So that is it. Here are my references, and I do thank you for your attention.
Carla, thank you so much. That was such a wonderful presentation on a very heavy topic, unfortunately.
Yes.
At
Thank you.
this time, we do have some time. If we're a small enough group, if anybody wants to ask any questions, please feel free to unmute and go ahead and ask your question. I will say I kept up on Savannah's law, or what went into place, and I'm so happy to see that it passed, and Tennessee was the first to put it in. My daughter comes from an abusive relationship, and that was something that we were very excited to see that go in. Very
Yes.
necessary. So
I'm sorry to hear about that.
fortunately, it's happening. I mean, everybody knows somebody that's been affected in some way. So.
And the more I give this, the more I learn of people I
Mhm.
wasn't aware of.
Mhm. And the tips that you provided were, fantastic. So I will be sharing the PowerPoint that Carla went over that'll have all those resources there for you. We will also be sharing the recording, so you'll have that as well. And Carla, if you have no if you don't care, can I include your email address if people have specific questions for you? Because it is a sensitive topic. People may not want to ask questions right now. Is that okay? I'll share your email address. Okay.
That's fine.
All right. Well, it doesn't look like we have any questions. You covered the topic wonderfully. So,
Thank you.
So I do want to thank everyone for joining us today for today's webinar, and a special thank you to you, Carla. It was fantastic. We do truly appreciate everyone taking the time out of your busy schedules to invest in your personal and professional growth. Your dedication to advancing your career and the nursing profession as a whole is inspiring, and we hope that you're leaving today with valuable insights. Before we wrap up, I do want to remind you that you will be receiving an email shortly containing your participation certificate and access to the webinar recording. Additionally, in the email, there will be a short survey. If you would please fill that out, we would greatly appreciate your feedback to help us improve and tailor future sessions to your needs. Again, thank you again for your participation, and we look forward to supporting you as you move forward in your nursing career. I hope everyone has a wonderful day. Thank you so much.
Hey, Carla, if you can stay on I actually have a question. I'm sorry. If you can stay on for a second with you being involved with GOVA. So as you were talking, and as you mentioned, a lot of domestic violence, a lot of people die because of gun use. And I'm looking at Bill HBO 387, and it looks like it's going to be going to session again this year. They're trying to, I guess, determine if providers, if they will be penalized if they ask about if you own a gun in the home. What's really driving that? And what do you think is going to happen with it?
I don't know. I haven't heard any discussion about it this year. I did hear testimony last year, I think, from a pediatrician who said it's not meant to target anyone. It's just the screening questions like, do you use a car seat and do you use a gate on your stairs? It's just is there access to guns in your house to keep them away from children? So that's I hadn't even thought about that for this year, but thank you for bringing that up.
Yeah, I just find it interesting because I think, in terms of pediatrics, I think it is a very important question. And then if somebody comes in that it's very obvious that they are in a really bad situation, I just I think there should be some reasonableness when you can ask the question. I mean, we ask about abuse anyway on some of the screening. So I was just curious what your thoughts were about that. So thank you.
Thank you for bringing it up.
Right. Do we have any other additional questions?
Hey, Carla, I sent you a chat, just kind of a one-on-one chat, but I really appreciate, your emphasis. I was part of that grant team that helped try to get, the same programs redone, started back up in West Tennessee. And my sister, just in full disclosure, was a victim of domestic violence when I was younger. And so, like, I would be interested if anybody would be looking at this further. I think sometimes we don't look enough at they talk about when this happens, about the kids of the victim, but sometimes I think they're in a kind of what I call the innocent bystanders. And I think we have a lot of work maybe as nurses that we could do is expanding that scope and looking at the impact of traumas like this or experiences on those other family members and maybe kind of addressing some of the issues that they may experience. So if you're ever interested in like kind of working that angle or going further, I'd be happy to collaborate with you or anyone else on that. So just another topic I thought about, but this was great today and I really appreciate you're putting this together and really continuing to draw, attention to, the problem that we have with that. So thank you.
Thank you. And as I did mention, I'm trying to remember who some of the groups were. I think Heal 901, maybe CVRCC, Rape Crisis Center, educators are some of the ones trying to get into schools and kind of flesh out some of those kids that are in abusive situations and to talk about the healthy dating. And so there are some agencies that are trying to get to some of the children.
Right. If we don't have any additional questions, thank you everyone for joining today, and special thank you to Carla. That was wonderful. Everyone have a great day.